Look at me.
Okay.
Hi everyone, and we're back live here at the Guidewell Insights Lounge. This is Kate Warnock on location at the AHIP Institute and Expo. I have Mr. Michael Chernew. Michael, welcome to the interview.
Thanks for having me.
You're welcome. So I'm going to say your title. You are the Leonard D. Schaeffer Professor of Healthcare Policy and also the Director of Healthcare Markets and Regulation Lab at Harvard Medical School. So you flew in all the way from Massachusetts to be here with us, and I know you're getting ready to go on stage. So we're going to be really sensitive to your time. Let's get right to it. Dr. Chernew, tell us more about value-based insurance design and how might this help seniors and those with chronic conditions who might otherwise forego care?
Right. You know, Kate, we live in an era where patients are being asked to pay more out of pocket when they go to the doctor or the hospital, when they go to the pharmacy to buy their medications. And that's largely done because payers are trying to control healthcare spending, but it creates a financial barrier for patients to access the care that they really need, particularly those who are trying to manage chronic conditions. So if you have diabetes, you're paying more for your medications, you're paying more for your glucose strips and a whole series of things like that. The idea behind value-based insurance design is to reduce the financial barriers for those high-value services, the high-valued pharmaceuticals, the high-value medical care services for individuals, to allow them to access the services that we want those people to access without having to pay a lot out of pocket.
Okay, what's the secret sauce? How are you managing to do this? How are you making this care more affordable?
Well, usually what happens is the insurance companies change the benefit structure to allow certain services to be covered more generously than they otherwise would have been. So there's examples of large companies, for example, that make patients or their employees pay less for their blood pressure medication, for their glucose medication, things like that. It really is a tweak to the benefit design.
Okay.
It doesn't necessarily save money. It might save money depending on how you design it. There's a possibility of charging people more, for example, for low-value services, which is also part of value-based insurance design. It really is dependent on the organization that is implementing these types of policies and the extent to which they want to be more nuanced in how they set up their benefit packages.
Okay.
But it's very rare. I talk to a lot of insurers. I'm here. There's a lot of insurers here. I talk to a lot of employers. I actually chair the benefits committee at Harvard University, which advises the provost. And you rarely find any payer, an insurer or an employer, that really wants to charge people with chronic conditions more for those services that are really important for those people to use.
Sure, sure. All right, next question then for you. So how might payment reform make primary care a more viable career for today's med students? And can it help solve for the shortage of primary care physicians?
Yeah, so completely different ballpark of question, but nevertheless I will take a stab at this. Historically, we've paid physicians in this country fee for service, and the general thinking has been that the fees for primary care physicians have been relatively low. There's also a belief that there's a considerable amount of waste in the system. Some estimates suggest as much as 30% waste in the system. The new payment reform initiatives all are designed to allow the delivery system, broadly understood, capture some of the savings if those efficiencies are taken out of the system. The key question is who gets to keep the share of savings. So if we reduce an unnecessary hospitalization, if we reduce an unnecessary stay in a SNF or some other unnecessary post-acute care, if we reduce the number of unnecessary imaging that's done, all those savings under these new payment models get shared with the providers. The question is whom? Most of the models now that are population-based favor the primary care physicians in terms of keeping those savings. The savings accrue, the portion of the savings that are shared accrue to the organization that employs the primary care physician. It could just be a primary care physician group. It could be a larger organization that employs primary care physicians. That process, should it play out in the future, conceptually would make it more rewarding to be a primary care physician because the primary care physicians are central to these population-based payment models. And if that proves to be true, and we're a long way from proving it to be true, but if that proves to be true, it will make primary care, I believe, a more valued part of the healthcare delivery system.
Well, I wish we had more time to talk to you. We have just one more question for you, though. So, what is your opinion on quality measures in use to gauge clinical performance? Can they be improved, and what might those look like?
Sure. So, again, you've saved the hardest question for last. one of the challenges for all of the transformation of the healthcare system is how do we measure quality? And there's an enormous amount of effort going on to quality measurement. There's National Quality Forum, there's NCQA, there's a number of organizations. CMS has huge initiatives. AHIP has been involved in a number of initiatives for quality measurement. The challenge has always been that although we've made a lot of progress, there's huge gaps in quality. A good example would be we don't have great measures around the quality of diagnostic care. How well are people who come in with unknown ailments being diagnosed?
Right.
Just one example. I think the improvements going forward will involve two things. One is coming up with better measures, which we're doing a lot of, but more importantly, I think it's important to understand that the way we think about quality measurement should not be simply about the measures, it should be about the measurement system. What is the system of measurement? How do we build a series of questions and a series of actions to understand who's providing good and who's providing poor quality? And so that requires understanding how the measures relate to each other. It involves measuring for a purpose, understanding what you're going to do with the measures. How you measure quality is different if your purpose is to inform consumers versus if your purpose is to pay providers, because consumers need more targeted measures about specific providers, whereas for payment you might just need to know aggregate quality for a given delivery system. So more focus on why we're measuring quality and more focus on the system around the quality measures, not just the measures themselves, is I think where we're going to have to go in the future.
Well, I know that you're going to have a wonderful audience waiting to hear you as you get ready to jump on stage here at the AHIP Institute. Thank you for spending your time with us here in the Guidewell Insights Lounge, Dr. Chernew. So my name is Kate Warnock. Please keep watching. We'll be up soon with another interview.
Great, and thank you.
All right, thank you.